Okay, good morning. My name is Cristian Yamilet Jimenez Colindres. I am a resident of second years of the specialty of radiology and image of the Hospital Universitario. My case today is about a 22 years old male who arrived at the emergency service on May 25 this year due to an increment in volume in the right hypotenar region after having suffered and puncture coating trauma of 1 month of evolution. The ultrasound is performed in the region. We can see a round Imagen with well-defined edge, anechoic, and with posterior acoustic reforming, as well as edema and adjacent of tissues. Up an examination with color Doppler, we can see the sign of yin-yang, which correspond to the blood flow of entry and exit observed in a pseudoaneurysm. The distal third of the ulnar artery was examined, observing a fine flow to the spectral Doppler scan. The basilic vein and the ulnar veins were also explored, which present adequate compressibility without observing aneurysmal dilatation. The pseudoaneurysms of the ulnar artery. The incidence of third extremity aneurysm are rare and represent less than 2% the peripheral arteries. Most affected vessels is a humeral artery, brachial artery, and axillary artery. The aneurysms and pseudoaneurysms, the distal ulnar artery, are even more infrequent. The main etiologic mechanism is the repetitive trauma in the most vulnerable portion of the ulnar artery. The most vulnerable portion of the ulnar artery is the point around the hook of the hamate bone in the wrist. The clinical presentation is the progressive growth of the tumor, usually pulsative at the site in the trauma antecedent and paresthesis. The cause is a iatrogenic, is a puncture with a angiography in needle. The incidence increments with the use of large calibrated Cyst, postoperative anticoagulation therapy. And traumatic is a stabbed wound, direct bowel, and fracture, infection, and idiopathic. The diagnostic method is a Doppler ultrasound in angiography and angiotomography and angioresonance. The treatment is a conservative, and the small pseudoaneurysm less 1 centimeter can spontaneously form thrombosis. Embolization success rate 90%, but falls 60 and 17% if anticoagulation is used. The aneurysm more than the 7 and 10 days age association and infection, intense pain, discomfort, and large bruise. That's it. Thank you.
Good morning, my name is Dr. Minerva Carolina Uribe Martinez, and my professor is Dr. Matias Salinas Chapa. Today I want to present you my radiological case. First of all, a little of clinical history. We have a patient, is a male of 76 years old, with a history of left renal cell carcinoma. The patient underwent surgical treatment and chemotherapy and was referred for a follow-up study in our department. In this slide, we have an abdominal enhanced CT, and it's an arterial phase with a mediastinal window, and we can see the heart and the aorta. If we go in lower slides, we can see the liver. We don't identify any lesions. The gastric wall is normal. In the lower slides, at the level of the kidneys, in this slide, we can notice the surgical absence of left kidney, and in its topography, we can see an irregular, ill-defined image. Ill-defined image, and with enhancement, with approximate measurements of 3 by 2 centimeters, that is compatible with a tumor recurrence. So our first finding is a tumor recurrence. Now we can see the venous face, we can see the upper thorax, and we can see a pulmonary nodule at the apex of the left lung. That with the patient record, we must suspect a metastatic disease. This is the pulmonary nodule. And in the lower slides, we can see a soft tissue lesion with an osteolytic involvement at the level of the third right rib. And the lesion is biconvex with contrast enhancement, and it measures 9 by 5 centimeters, which corresponds to a metastatic lesion. We can also see the degenerative change of the column characterized by marginal osteophytes. And we keep seeing the metastasis to the thoracic wall. So our second finding corresponds to a metastatic disease. Continuing with the rest of the study, at the level of the kidneys, we can see the tumoral recurrence in the topography of the left kidney that I already mentioned. The patient has calcified heteromatous disease, like is very obvious in these slides. Let's go to a lower slides, and in the right lower quadrant, we can see the appendix. Please pay attention to the appendix. We can see the bladder. And we can see in this slide a vesical stone is observed, also an enlarged prostate, and please pay attention to the bladder. It catch my attention that the right anterolateral vesical wall is thickened, and we can see the appendix inside the inguinal hernial sac. We can see a right inguinal hernia of bladder and appendicular content. No effacement is observed, neither complication data at the time of this study. This is a sagittal view. As we can see, the hernial sac with the appendicular content. In these slides, we can observe the bladder content. In this coronal view, we can see the anterolateral wall of the bladder that is inside the hernial sac. Well, let's talk about bladder hernia. It's the output of a bladder portion through a hernial sac. Most bladder hernias involve the inguinal and femoral canals. It is an infrequent pathology with an incidence of the 1%, and a predilection for the right side has been reported. Most often, bladder hernias appear in elderly male patients. A variety of factors can contribute to the development of bladder hernias. Some of these factors are urinary outlet obstruction, like prostatic hyperplasia, as we have this patient, urethral stricture, prostatitis, loss of bladder tone, weakness of the abdominal wall, factors that increase intra-abdominal pressure, like obesity and presence of space-occupying pelvic masses. Most bladder hernias are asymptomatic, but patients with large hernias descending to the scrotum, is that we call scrotal cystocele, have symptoms such as dysuria, frequency, urgency, nocturia, and hematuria. The most characteristic clinical sign of a large cystocele is the Mary sign. What is the sign? Is that a two-stage micturition, a situation in which initially the patient empties the normally located bladder and then voids again after manual compression of the hernial sac. The diagnosis can be made clinically. Nevertheless, most bladder hernias are asymptomatic and discovered incidentally during surgery or during imaging studies performed for other purposes. The treatment is the reduction of the hernial sac with hemorrhaphy and treat the cause of the increase in abdominal pressure. In the case of our patient, the risk factor was the enlarged prostate. Let's talk about appendicular hernia. It was described for the first time by the French surgeon René Jacques Cousin de Garengot. It's a rare entity. It's a rare form of inguinal hernia in which the vermiform appendix is located within the hernial sac. It is seen in less than 1% of inguinal hernia. In clinically, manifests a typical presentation of acute appendicitis is suspect, and the clinical presentation may mimic an incarcerated inguinal hernia, and it's until surgery that we can get the correct diagnosis. The treatment is an appendicectomy and a neoplasty, and in the image we can see a surgical piece of a patient. So, in conclusion, these entities are very infrequent, are very rare, and it catch my attention that my patient has two of these entities. That's why I found this case very interesting. And it's all on my part, and thank you very much.
Good morning, my name is Franklin Orlando Ordóñez, and this is my interesting case. As a 17 years old man patient present with fever, toothache, and pain in the right cervical region. Physical exploration, increase of volume and erythema in the right submandibular region that extend towards submental with pain, flution, and heat in the area. Lab values were significant for a white blood cell count of 16,000 with neutrophil predominance, 82.6%. We decided to make an ultrasound evaluation. It came to our attention this imaging at external carotid artery, and it's an anechoic and hypoechoic round imaging with central Doppler sign simulating a yin-yang associated with fat stranding and local edema. Ultrasound examination of the external artery using linear probe and grayscale and Doppler color. Okay, the yin-yang sign. And the other imagine yin-yang sign, and the lesion was approximately 2 centimeters, approximately. Before pseudoaneurysm, the velocity was high, as you can see in this imaging. Okay, after pseudoaneurysm with systolic velocity, approximately 245. Okay. And axial and chase CT showed abscess in the size assessed by previous ultrasound, as you can see in this imaging. Okay, axial CT imaging at the head and neck with contrast reveals a well demarcated imaging within the right side of the neck, significant edema and mass effect adjacent structures, including airway, are evidence. Okay. Here in this reconstruction, we can see the connection the right external carotid artery proximal to the carotid bifurcation is in coronal and sagittal reconstructions. Okay. And the value rendering imaging demonstrate a saccular dilatation of the right external carotid artery, as you can see in these images. Now, and at the exploration from digital subtraction angiography of the right external carotid already demonstrate the aneurysm at the vascular afferents for external carotid, as you can see in these videos. Another digital subtraction angiography is showing the aneurysm in different views. Okay. Now, after these findings, the planned treatment was a stent placement in the external carotid artery and pseudoaneurysm thrombosis by the percutaneous thrombin injection. Okay, in this video we can see the percutaneous thrombin injection on the aneurysm shows thrombus formation. And there is no more flow after the percutaneous thrombin. Okay. Digital subtraction angiography of the right carotid artery demonstrate that there is no more flow. Okay. The post-surgical node is drainage and debridement of the abscess in the neck, embolitis material, thrombosis, pseudoaneurysm, and trace of purulent material, approximately 20 cc, are removed in favorable evolution. And the diagnosis was acute mycotic aneurysm of the external carotid artery. Okay, infected aneurysms are uncommon. Approximately 100 cases of external infected carotid artery aneurysm has been reported in the books. Other clinical study shows 20 cases per 10 years in USA. Infected aneurysms can develop from hematogenous spread, contiguous involvement, direct infection, inoculation of the vessel wall at the time of vascular trauma. Complications: rupture, several infection, treatment, surgical, endovascular, and antibiotics. And the prognosis, there is a mortality of 70 to 90% if not treatment, sorry. And the treatment makes mortality lower than 10%. Clinical evaluation is variable. And this was my interesting case.
Good morning, my name is Ricardo Alvarez, third year resident from Hospital Universitario, and we're going to continue with clinical cases. My clinical case is a 20-year-old pregnant woman with a gestational age of 17 weeks with acute abdominal pain without vaginal bleeding or discharge. We made an ultrasound where we found a normal fetus in utero with a cardiac frequency of 153 beats per minute. And we found the ovaries, where this is the right ovary and then the left ovary, when we can see that the right ovary is enlarged than the other one. The right ovary is increased in size with a measure of 5 per 4 per 4 centimeters and a volume of 42 cc. We found by ultrasound that the ovary is echogenic, rounded, and in its interior we found a round cystic image, well defined, measuring 2 per 2 per 2 centimeters and a volume of 4.2 cc. This was the relation to a corpus luteum cyst. Also, we found that that in Doppler exploration we didn't show flow in the ovary. And also we made a fast ultrasound, so we found free fluid observed in the right iliac fossa. The gynecologist also wanted to see a MRA, so they can be sure that this was the cause of the abdominal pain. So here we have two images in T2, two axials and two coronals, when we can find the right ovary over here. Increases in size, rounded, well defined, with hypertense corpus luteum cyst in its interiors and free liquid in fossa iliaca, right fossa iliaca. Also, we can find the appendix, normal appendix, in a measure of 6 millimeters. So with this image, we made the diagnosis of an acute right adnexal torsion with the corpus luteum cyst. Okay. So adnexal torsion is more frequent in adults, like from 50 to 90% is associated with an ovarian mass, usually benign, like a large physiological follicular cyst or a corpus luteum cyst is the most common. In children is most associated with the hypermobility due to the long mesosalpinx. This is 2 per 3% of all gynecology's emergencies. Is more frequent on first 3 decades and is more common during the pregnancy. Usually before 20 weeks. This is because the uterus enlarged, ovary produces a push out of the pelvis, increasing the risk of torsion. The presentation is severe unremitting acute pelvic pain. Pain may be intermittent or from the torsion and the torsion. We can see the adnexal mass that may or not may be palpable. Vomiting is common, and fever is ovary if the ovary is in fact infarcted. So by ultrasound we found an ovary that is enlarged and heterogeneously echogenic ovarian trauma with multiple cysts that are on the in the peripheral. And sometimes the ovary is tender to touch by the ultrasound probe, and we can find free fluid on the pelvic with low level echoes. In Doppler, we need to the flow pattern depends on the degree of the vascular obstruction and chronicity of the torsion. So normal arterial and venous waveform may be present, especially in acute torsion, but the venous flow is affected first. So this is because of the dual artery blood flow supplied by the ovary. Okay, absent venous and arterial flow is late in the ovary infection. In MRA, like the image of the case clinic, we found a ovary that is enlarged, containing a large cyst. This was the same with a patient with a pregnancy. The principal differential diagnosis is hemorrhagic corpus luteum that can be confused with this. But the appearance is different. We can find that recreating fluid level, a diffuse low level echoes, or increased flow around cyst and color Doppler. The treatment is surgical untwisting in the non-infarcted adnexal, careful examination of the removal or any mass serving as a lead point, or a salpingo-oophorectomy if the ovary is infarcted. And that's all.
Hello, good morning. We will continue with the case reviews. My name is Juan Pablo Montemayor Lozano. I am resident of third grade from the specialty of radiology at the Hospital Universitario, Dr. José Eleuterio González. The patient is a female who is 28 years old, and the clinical symptom is a palpable mass on right epicondyle. The patient there was an ultrasound first as a first imaging approach. We didn't have that, but in the ultrasound they found a cystic complex cystic mass in the right epicondyle. So they suggested to undergo under contrast intensity to the patient. Here at the scout of the tomography, the only relevant image, the only relevant finding is inferior displacement of the intestinal gas here at the right epicondyle. And also, well, I don't know if you can hear it at this image. It can be seen, but it has calcifications that. A ver. Está. At the CT we have we have three actual images. This is our oblique reformatted image. We and the non-contrast in change, we find a rounded, well-defined mass with which is we has a cystic portion and solid portions. This also has dystrophic calcifications. The solid part has a relevant engagement after the contrast administration. Also has a thick septa. And a very important finding in this patient, it was that the pancreatic duct it wasn't dilated. Here we can see in a coronal reformatted image, the mass displaces superiorly the liver and inferiorly the intestinal the intestinum. And well, we see that this mass is it arises from the head of the pancreas. You can see that the claw sign with the pancreas, and when also the dystrophic calcification, the more septa, and the papillary projections. Due to the age of this patient, that is a young woman with a big mass with papillary projections. The first differential diagnosis that we made it was the solid pseudopapillary tumor of the pancreas, which was later confirmed by pathology. The patient undergone surgery and now is asymptomatic. We'll talk about the solid pseudopapillary tumor of the pancreas. This is a epithelial tumor of the Sacrum pancreas with a very low malignant transformation risk and also with solid and cyst features. The total of these tumors, only 10% metastasize or recur, and it's associated with a very low risk of mortality of only 2%. It's a pretty uncommon tumor. It's less than 3% of the total of the pancreatic tumors. Also, this pathology is defined by the WHO as a low-grade malignant tumor. Before they there was like described like two subtypes, benign and malignant type, but now the WHO encompasses all of this as a low-grade malignant tumor. And epidemiology is 90% female, and the age is less than 35 years old. Well, this tumor is defined as a big complex mass with capsule, and it's with absence of the pancreatic duct dilation. The most one of the common places of appearance are first the tail with 50% of the total, then the head with 36%, and at last the body with 14%. It has dystrophic calcification associated. And well, when we are in front of one of these tumor, we have always to look for malignant features. What are the malignant features? Well, there are perivascular invasion and metastasis. Like this in this example, in the inferior row, we see two images. We have the primary tumor, which arises from the head of the pancreas, and at the liver, we see multiple nodules. We have also papillary projections with enchangement, and this is our metastasis, which are the most common places to that this tumor metastasizes is to the liver and to the local regional lymph nodes. And for the size, this due to these tumors are mainly asymptomatic. The most common symptom, when they present with symptoms, the most common is abdominal pain. But due to their benign features, or because these are don't tend to invade, they usually are pretty big at the diagnosis, with a mean size of 10 centimeters. Well, at ultrasound, how will we find this tumor? As well, we will find it as a heterogeneous mass with solid and cyst components, with fluid levels, also present at the inside of the cystic portion. And also due to the cystic component, we will find posterior acoustic enchangement. At the color Doppler exploration, we will find little to none flow. Well, at CT, the solid part has an heterogeneous attenuation, and and also it has a post-conscious enchangement at the capsule and the papillary projection, which is also very distinctive of this tumor. Well, at MRI and T1 weighted images, the capsule and the solid components, these two images are T1 weighted. We have that the solid components and the capsule have a low signal, but after the administration of gadolinium, they have enchangement, like this T1 weighted images with gadolinium. We have a homogeneous enchangement of the capsule. And when we find a high signal and the T1, we can suggest that this is hemorrhage. And then in T2, the necrosis and hemorrhage will be see as a high signal, and the fibrous capsule, due to their components of fibrous tissue, will be hypointense. There is it's suggested that for this patient the CT and the MRI are the best imaging studies. But the MRI is it's a little superior than the CT for characterization of the cystic portion. Well, the treatment, it's surgical, and there's and if there is no metastatic or malignant invasion or lymphadenopathies, there's an excellent prognosis. And let's go with the differentials. The first differential is the Messina cystic neoplasm. It has a similar appearance due that this is a cystic mass with well-defined. It tends to have septa and dystrophic calcifications, but the difference with the solid subpapillary tumor is that it's seen in female, but of 40 to 50 years, and it's as it says in the pneumogenic is 40 to 50 is the mother tumor, and it has one or multiple cysts. The other is the serocystic neoplasm. This is a benign tumor typically seen in the elderly woman, or also known as the grandmother tumor. This has a microcystic or honeycomb cyst appearance with a central scar, which is found in 1/3 of the cases, and also with dystrophic calcification. And there is no communication between this cyst and the pancreatic duct, so there is little to no chance to have a pancreatic bile duct, the pancreatic duct dilation. And the last differential is the pancreatic adenocarcinoma. Is the most common malignant tumor of the pancreas. This is an infiltrative solid mass. Contrary to the pathology that we are reviewing, this rarely shows necrosis or hemorrhage. And as a very common sign, common presentation, we will have the pancreatic duct dilation and pancreatic atrophy. And contrary to this tumor, this is a little more common in men. The relation is 1.5 to 1, and the age it's a little more older. It's between the 60 and 70 years. And the pearls for this tumor is it's to consider a pancreatic solid and pseudopapillary neoplasm when confronted by an encapsulated solid mass in young women, like the patient that we just see. Thanks.